read this, tell me this little bit on the next page. This is the question that you have to put in.
Yes, ma'am.
Right. If you have read and understood considering this critical care scenario, kindly tell me how would you manage this patient?
Yes, madam. This patient is suffering from systemic inflammatory response syndrome secondary to acute pancreatitis, most probably, and we are going to manage this patient according to CRISP protocol. We are going to perform an ABCD survey and then act accordingly.
Okay, then?
Yes, we are going to check the Glasgow score of this patient, and this involves the checking of arterial saturation of oxygen, serum calcium levels, white count, serum urea levels, and serum albumin as well as sugar levels. And if the score is more than 4, then this patient is in ICU.
What are the other differential diagnoses that you'll consider other than acute pancreatitis?
Apart from acute pancreatitis, this could be peptic ulcer disease or an abdominal aortic aneurysm.
Okay.
Or it could be cholecystitis or
how would you confirm your diagnosis?
Pancreatic pseudocyst. We will perform some blood investigations that include a full blood count, that includes a leukocyte count. And in this case, we already have a serum amylase reading that is in favor of acute pancreatitis. We are going to perform
Is it
ultrasound
a confirmatory test for the diagnosis of acute pancreatitis?
It is not a confirmatory test. It is not very specific for. It can also rise in other conditions as well.
Okay.
But we are going to perform serum lipase as well, and CT scan of the pancreas to see the further.
Considering the fact that it is acute pancreatitis, what is the pathogenesis behind it?
The most common causes are alcohol abuse in West and gallstones in East. Apart from that, viral infections, post-procedure, high calcium.
There'll be pathogenesis is how the disease occurs or takes place.
Yeah,
so then you have to tell me about the duct obstruction and all those.
Yes, duct obstruction with the leakage of enzyme in systems that will cause autodigestion of pancreas as well as surrounding fat.
Yes.
And this will generate a severe inflammatory response causing the different organ failures or involvements.
But then which enzymes will be released? You have to tell me the all sequelae. If you can't today, then we'll do it again. All right. You were telling me about how many criteria there are which you can take help of to confirm your diagnosis of.
Yeah, there is one is Glasgow criteria. The second is Balthazar CT scan, and the third one is Ransom criteria.
Okay. Please tell me about the Ransom criteria on admission and after 48 hours. How is it different?
Yes, on admission, the parameters that are taken are increase in white cell count, age of the patient more than 55 years, rise in
TLC.
Yes, rise in TLC and rise in enzymes like LDH and AST.
Yes.
More than 350 and more than 450. And at 48 hours, we are going to check the sugar levels. That should be more than 11.
Yes.
Yeah, that will be in the first one, the rise in sugar levels as well. And after 48 hours, we are going to see for low oxygen level. that is less than 60 millimeter per mmHg, and
low calcium level,
low serum calcium level, and low
base
serum
deficit.
albumin level.
Yes,
And base deficit more than 4 base deficit.
Yes.
These are the Rensen criteria at 48 hours.
Yes. According to this Rensen criteria, how would you categorize the patient into mild, moderate, and
yes, if the score is less than 2%, then if the score is less than 2, then it's 2% chance of mortality.
Yes.
If it goes up to 4, then the mortality rises to 15%. As the score rises to 6, then there is a 40% mortality, and more than 6, it is 100% mortality.
This patient is tachypneic. Can you explain why?
Yeah, this patient is tachypneic. Possibly it could be as part of systemic inflammatory response syndrome, and the patient might be having ARDS. Other possible causes may be due to pain and splinting of the diaphragm that may lead to shallow breathing and tachypnea.
Okay, how this ARDS and VQ mismatch leads to tachypneic situation of the patient? Can you explain?
Yes, because of the inflammatory response, there is thickening of alveolo-capillary membrane that makes it difficult for oxygen to transfer across this membrane. And because of that, there is a VQ mismatch, that is the shunting of blood from those alveoli which do not allow the transfer of oxygen.
Can you please mention 2 situations in which, in case of acute pancreatitis, serum amylase level would be normal?
Yeah, if it's taken too late, like more than 48 hours, it might be possible to get a normal level. Or if it's taken too early, then it will not be very high.
All right. Can you tell me, how would you take care of the vitals of this patient? Blood pressure is 40.
Yes, this patient is having a severe inflammatory response syndrome, and we need to again approach take the ABCD approach. We have to put patient on supplemental oxygen. We have to pass a CVP line to monitor the fluid balance of the patient. And because of there is third space loss, we need to give him IV fluids, as well as if the need arises, a fall in hematocrit, when we also need to transfuse blood in this patient.
And how would you take care of the nutrition of this patient in this situation?
Yeah, the patient will require bowel rest, and it is quite possible for us to give him a TPN for a long period of time. We are also going to give him sandostatin, that is going to reduce the pancreatic secretions, and NG tube will be passed to decompress the stomach as well.
Good. Okay. This patient has pain as well. How would you take care of the pain of the patient?
Yes, we need to increase the dose of painkillers, and usually we can use a patient-controlled analgesia or epidural route for pain control, because usually the morphine cannot be tolerated by these patients.
Yes,
and NSAIDs are not a good option.
Yes, but then you will say that you will follow the WHO's pain management level. Yes, not just, okay. If you fail to manage this acute pancreatitis, what are the complications that can occur?
Yeah, a patient can develop multi-organ failure that follows the systemic inflammatory response syndrome. Yes. Apart from that, the patient can develop sepsis following the necrosis of pancreas. And then there can be pseudocyst formation.
All right, okay. For the pseudocyst, please tell me, how would you confirm? What are the components of the pseudocyst?
A pseudocyst is amylase-rich fluid that is lined by a fibrous and granulation tissue lining, and it usually takes 4 to 6 weeks to develop after an acute pancreatitis. And it usually presents with decreased appetite, early satiety, vomiting, and epigastric pain or mass.
Good. Other than serum amylase, what other blood test would confirm or would give you the suspicion of pseudocyst, presence of pseudocyst?
Yes, serum lipase is more specific than serum amylase.
No, pseudocyst. Other than persistent high serum amylase, what other blood test would give you suspicion of
I'm sorry, ma'am. Maybe white count, but I'm not sure.
high bilirubin? Will be
Yes, I'm
obstruction.
sorry.
No, but
Yes.
now you know.
Yes.
That's okay. No need to be sorry. One can forget.
Uh,
Good.
uh.
You told me everything very nicely. Good, excellent.
Thank you, ma'am. Thank you.